Hello everyone, my name is Dr. Alessandra C. Schmitt. I'm a surgical pathologist and cytopathologist at the Mayo Clinic in Scottsdale, Arizona. And today I'll be sharing with you my didactic lecture about salivary gland fine needle aspiration. So I will start my lecture with an overview of FNA in salivary glands. We'll go over the normal elements, and I'll start this presentation with the two most common lesions. We'll discuss the Milan system and the diagnostic groups based on morphology, and throughout my presentation I'll be sharing with you 9 interesting cases, and we'll finish up with some take-home messages. So why FNA, not biopsy? Well, FNA is better for the patient, it's safer, it's simpler to perform, it has less complications, and also both FNA and small biopsies share the same limitations. But with FNA, we should be able to answer some basic questions. For example, is it neoplastic or not? Does it need to come out or not? Is it low grade or high grade? And if it's high grade, the patient will need a more complete resection, more aggressive resection, maybe take out some lymph nodes. Is it a primary salivary gland or is a soft tissue lesion? Is it a metastasis? So based on these questions that will be answered, the surgeon will be able to plan treatment. So this is how normal salivary gland looks like. You have this grape-like configuration, very organized, gland-looking cells with a mixed fat, and also some intercalated ducts here and there. So these are the two most common salivary gland neoplasms, Pleomorphic adenoma and Warthin tumors. So pleomorphic adenoma is a classic example of how a basaloid neoplasm should look like. So you have these small looking cells with high Ancillary ratio, epithelial cells, myoepithelial cells diving into the stroma, and the reason why it's so hard is that many times you can have squamous metaplasia in Warthin adenoma, you can have scant matrix, and that can make the diagnosis really challenging. So for Warthin tumor, it's a classic example of oncocytic neoplasm. You have cells with abundant oncocytic cytoplasm, that is round, uniform nuclei in the lymphoid stroma. Again, with Warthin tumors, you can have some metaplasias, you can have squamous metaplasia, you can have mucoid metaplasia, and that can make the diagnosis look can be very challenging. So pleomorphic adenoma is the most common salivary gland, both in children and adults, benign, slow-growing, painless. It has PLAG1 and HMG2 gene rearrangements. On immunostains, you can have staining for PLAG1, occasionally staining for HMG2 and BLEF1. It's usually located in the superficial parotid lobe. It can also be located in submandibular gland and minor salivary glands. On cytology, we can make the definitive diagnosis as long as we have this classic triad of epithelial cells, myoepithelial cells, fibrillary or chondromyxoid stroma. The epithelial cells, they look very bland. They form sheets or clusters of oval cells with very high Ancillary ratio. They can also form ducts, trabeculae, glands, papillae. The myoepithelial cells, they can have a wide range of morphology that they can look like. They can look spindle, they can look stellate, they can look plasmacytoid, but a very important feature is that they dive into the stroma. They are very mixed with the background stroma. The stroma can also look different according to the stain. It looks bright red in the Diff-Quick stain and bright pink, I mean, in the Diff-Quick stain, a little feathery, and it can look pale blue to green on the Papa Nicolau stain. You see the cells diving into the stroma, the myoepithelial cells very admixed with it. This is how they look in the cell block. It looks a little bit like cartilage. The myoepithelial cells dive into the stroma. So Warthin tumor. Warthin is the second most common salivary gland neoplasm. It's more common in males, smokers. It can be bilateral and cystic. And we can make the diagnosis again if we have these features here: lymphocytes, oncocytes, sometimes granular debris. Now, a very significant pitfall for Warthin tumor is that Warthin can be PET positive. And that can be a very, very tricky thing, since the clinicians might think it's malignant, and you might receive a sample already thinking it might be malignant. And also, if you have squamous metaplasia or mucous metaplasia and atypia, that can be a very, very significant tricky, pitfall in this to make the diagnosis of Warthin. So this is how Warthin, classic Warthin, looks like. You have this background of lymphocytes and debris, and then you have this group of bland-looking cells with low NC ratio, abundant oncocytic cytoplasm. And this is a closer view. The cells are very uniform. You can sometimes have prominent nucleoli, but they have abundant granular cytoplasm, and they're very uniform. So no pleomorphism whatsoever, and a bunch of lymphocytes in the background. So what are the pitfalls you can have with Warthin? Sometimes the aspirate might look purulent, and that may make you think you might be dealing with a necrotic neoplasm. And this is the cell block for Warthin. Very, very, lots of lymphocytes, lots of degenerated looking cells. But if you find the groups of bland appearing oncocytic cells, you might be reassured that you're just dealing with a Warthin and not with a necrotic neoplasm, even though the background might look very necrotic. So this is squamous metaplasia in Warthin, and this case was misdiagnosed as suspicious for squamous cancer because the patient had a PET positive lesion, and then the pathologist saw this atypical looking squamoid cells, and he was worried there was a metastatic lesion here. And I have the corresponding resection for you. So you see all these trabeculae where you used to see oncocytic cells. Now they are mostly all replaced by squamoid cells. But if you look hard enough here and there, you still find the bilayered oncocytes. And I have a closer view. You see the cells are very uniform, very bland. But on cytology sample, this case can be very challenging, since you can have some squamoid atypia. So this is the standard way to report salivary gland, the Milan system. And the Milan system is very helpful since it provides an estimate of risk of malignancy. And I wanted to point out these two groups here, the atypia of undetermined significance and the neoplastic group. So when is that we use atypia of undetermined significance, or, for example, salivary gland of uncertain malignant potential? So under this group here of the atypia of undetermined significance are lesions that sometimes they are neoplastic, but they're scantily sampled, or sometimes that is just atypia, but they might represent reactive atypia. And in the neoplastic group, we have two subgroups. We have benign, when we are able to say, okay, this lesion is benign, it's just a pleomorphic adenoma, or it's just a Warthin tumor. But still under this group, there is a very small chance it still might be malignant. And under the salivary gland neoplasm of uncertain malignant potential, we have lesions that we are sure are neoplastic, but we can't tell exactly what they are. For example, basaloid lesions or oncocytic lesions that we are not sure to which group do they belong. So according to the morphology, we can subdivide salivary gland lesions into all these groups: basaloid neoplasm, spindle cell lesions, oncocytic or clear cell, mucus-containing cysts, high-grade malignancies, and also lymphomas. But I would like to point out that sometimes there is a lot of overlap between the lesions, since some basaloid cells can look spindled. For example, a pleomorphic adenoma that has a predominance of myepithelial cells that look spindled, or sometimes myepithelial cells can look plasmacytoid and clear and oncocytic, and then they might look like they belong to this group. So it might be a little bit hard to separate, but overall they're very helpful to at least help you sort out your differential diagnosis. So among the basaloid neoplasms, as I already mentioned, we have pleomorphic adenoma. So whenever we don't have a whole lot of stroma and we cannot say for sure it's pleomorphic adenoma, for example, in a cellular PA, the pleomorphic adenoma is going to fall under this group. We also have malignant lesions like adenoid cystic adenoma and a variety of other benign, for example, basal cell adenoma, myoepithelial adenoma, and also malignant lesions like basal cell adenocarcinoma, myoepithelial carcinoma, and some other more rare lesions. And also, let's not forget metastasis. So we'll start with our challenging cases. Our case number 1 is a 50-year-old woman, and she has a slow-growing and painful mass in the submandibular gland. On this deep quick stain, you can see these basaloid cells, very high Ancillary ratio, somewhat hyperchromatic. They are sticking to this matrix. They are not diving and squeezing into the matrix. They are just surrounding the matrix. It's very dense hyaline matrix. On a higher power view, you see you have a variety of size of globules, and again, these hyperchromatic cells are sticking to the matrix. There is a hint of maybe a little bit of molding. So what's your FNA diagnosis? So these are some possibilities of how you could report this sample depending of how much cellularity you had, how much clinical information, and how pronounced the cytologic features were. Let's say if you're not very sure if this is benign or malignant, you could report as neoplastic, as salivary gland neoplasm of uncertain malignant potential, and then include a comment that this is a basaloid salivary gland neoplasm, and your differential includes adenoid cystic carcinoma, cellular pleomorphic adenoma, among others. But you could say suspicious for malignancy. Let's say you had a very cellular sample and you're very convinced you have hyperchromatic cells not diving into the stroma, you can say suspicious for adenoid cystic carcinoma. Or if you're absolutely sure you're dealing with a malignancy, then you call malignant. Let's say in addition to all these features, you have clinical and imaging features worsen for malignancy, like if the lesion is invasive, the patient has pain that could indicate perineal invasion. So this was adenoid cystic carcinoma, and this is the corresponding resection. You see here the hyperchromatic cells surrounding this matrix, and this matrix for globules of varying sizes with a little bit of molding and very hyperchromatic looking cells. So adenoid cystic carcinoma is the most common malignant in the minor salivary glands. Most of them have the MYB gene abnormalities by fish, and on immunostains you can have strong and diffuse staining with MYB, but MYB can be faintly positive also in other basaloid lesions. You tend to have also very strong staining with CD117, and LEF1 is usually negative. And this lesion usually has a slow growth and is painful and can have facial nerve paralysis. So comparing adenoid cystic with cellular PA. So on the right side, you have a case of cellular PA that was misdiagnosed on cytology as suspicious for adenoid cystic. And why did that happen? So you see the cells look somewhat very similar, and you don't have a whole lot of matrix in this case. So this case was very challenging, and the pathologist initially thought he was dealing with with an adenoid cystic carcinoma, but upon resection, it turned out to be cellular pleomorphic adenoma. So again, as I mentioned, most problems occur with the diagnosis of PA whenever the FNA is too cellular and you have scant stroma. So that's a very significant pitfall. And also, adenoid cystic carcinoma not always have the large globules of varying sizes. Sometimes all you have is just a little bit of matrix, very scant matrix, and then it's very hard to make the diagnosis. PA can have large globules, and that can mimic adenoid cystic. So on your left side, you have a case of PA that had somewhat larger looking globules, and the cells were not perfectly diving into the matrix. So that was a very challenging case. And on your right side to compare, you have adenoid cystic carcinoma. So with PA, whenever you have the very abundant stroma, it's a very, easy diagnosis, very simple. You have myoepithelial cells blending in with the stroma, very hypochromatic chromatin. Some of them have more cytoplasm, some are more spindle. In comparison, adenoid cystic carcinoma, the cells are a little bit more hyperchromatic. But in a case that you have the cells only, it can be really, really tough to distinguish PA from adenoid cystic carcinoma. Like you see in the sample here on your left side, adenoid cystic, on your right side, PA. And especially if the sample is paucicellular, it can be very tough. Adenoid cystic carcinoma can be also very difficult to distinguish from basal cell adenoma. So you have adenoid cystic on your left, the cells just sticking to the matrix, and basal cell adenoma on your right. Basal cell adenoma also has the basaloid looking cells with scant cytoplasm, but one more significant difference is that basal cell adenoma cells, they mingle more with the stroma. And sometimes if you see peripheral palisading like this over here, and this hyaline matrix forming this ribbon peripherally, that's an indicative it's not adenoid cystic carcinoma. You could be dealing with either basal cell adenoma or basal cell adenocarcinoma. And I have here a cell block that, again, you can notice the peripheral palisading. That's not a feature of adenoid cystic carcinoma. You have these tiny droplets here of matrix. Adenoid cystic carcinoma does not usually make these very small droplets like this. And also, if you look really, really close, you can see in the center of this cluster, you have a hint of squamous metaplasia, the cells with the squamoid-looking cytoplasm. So you should not see this in adenoid cystic carcinoma. Adenoid cystic carcinoma almost never makes squamous metaplasia. Are there any immunostains you could do to help you out? So all these lesions, adenoid cystic carcinoma, PA, basal cell adenoma, and basal cell adenocarcinoma, they are all composed of epithelial and myoepithelial cells. So these stains, to highlight these components, they are only going to be helpful if you're trying to differentiate a primary from a metastasis. And they're not going to be very helpful, to further subclassify these lesions. There are other stains you could do. For example, plaque 1 is usually positive in PA, but it can also be positive in pleomorphic adenoma X carcinoma. HMGH2 is only positive in about 20% of PAs. Adenoid cystic is usually strongly diffusely positive for MYB, but MYB can be faintly positive in other basaloid neoplasms. CD117 usually strongly positive in adenoid cystic carcinoma, but also positive in other lesions. LEF1 usually negative in adenoid cystic and can be positive in PA, basal cell adenoma, and basal cell adenocarcinoma, but not in a very high percentage of cases. Basal cell adenoma and basal cell adenocarcinoma tend to be nuclear positive for beta-catenin, but the stain is not going to be able to tell the difference between a benign and a malignant lesion. So we'll move on to the case number 2. This is a 50-year-old woman, and she had a 2 cm painless palate mass. So again, we have a basaloid-looking neoplasm, cells with very monotonous looking, with scant cytoplasm forming small groups. And here they have this more like papillary configuration and very bland looking, hypochromatic nuclei, very uniform nuclei. On the cell block, you have a variety of patterns. You have glomeruloid structures and papillary structures and sheets of cells. And this is the resection where you have this cribriform architecture with very bland looking cells. So this was polymorphous adenocarcinoma. Polymorphous adenocarcinoma was formerly known as polymorphous low-grade adenocarcinoma, and we don't use this terminology anymore because it's not always low-grade. Many of them have the PRKD1 gene fusions, it's almost exclusive to minor salivary glands. And the very characteristic feature about this tumor is that it has cytologic uniformity. The cells are very bland, somewhat basophilic, but architectural diversity. You have papillary structures, glomeruloid, cribriform, solid, and single cells. Are there stains you could do? There are, and we'll talk about them. So when you discuss, when you compare pleomorphic adenoma versus adenoid cystic carcinoma, again you can see that this feature of nuclear hypochromasia in a polymorphous adenocarcinoma is not so easy to distinguish from adenoid cystic carcinoma on the Papa Nicolau stain. And here are the stains, so you can do P40 and P63. And if you have this discordant immunoprofile of negative P40 and positive P63, you can favor polymorphous adenocarcinoma over adenoid cystic carcinoma. And why is that? Because polymorphous adenocarcinoma does not have true myepithelial cells. It has some staining for some of the myepithelial markers, but this discordant immunoprofile is helpful to favor polymorphous adenocarcinoma. And the cytology may or may not be helpful to you if you have, hyperchromatic and ungulated nuclei. That is going to favor adenoid cystic carcinoma. But they both can have stromoglobules and strands, so the globules are not helpful at all in this distinction. So we'll move on and we'll discuss our next diagnostic category, the spindle cell lesions. Among spindle cell lesions, you have primary lesions. You have primary lesions that can be primary of the parotid, or they can be arising from adjacent tissues, like schwannoma, neurofibroma, and the most common spindle cell lesion would be a myoepithelioma. And I have an unknown for you, another parotid mass. So in this diff quick stain, you can see all these bland-looking spindle cells with not a whole lot of matrix. Or upon a closer view, you see the cells are very bland, very uniform looking, forming these cohesive groups. A little bit of matrix, some nuclear palisading maybe. On the Papa Nicolau stain, you can see the chromatin is very uniform. You can see more of the palisading. Closer looking view. No mitotic figures, so this lesion looks bland. What could this be? So spindle cell lesion with pointy nuclei and palisading could be schwannoma. So I was fortunate enough in this case to have a very good cell block, and I was able to do several immunostains. And this lesion was indeed strongly diffusely positive for S100, and had I done only that stain, I could have made a mistake and called this a schwannoma. But I also performed some epithelial markers and myoepithelial markers. So cytokeratin strongly diffusely positive, P63 positive. So this is myoepithelioma. S100 is also a myoepithelial marker. So that's a very, very tricky case. This case was signed out as myoepithelioma. However, I would advise to sign it out as, instead of flat out myoepithelioma, maybe a low-grade myoepithelial-rich neoplasm, because sometimes myoepithelial carcinoma can look very bland. And if you signed out as low-grade myoepithelial-rich neoplasm with a differential diagnosis, that this includes myoepithelioma, low-grade myoepithelial carcinoma, and pleomorphic adenoma, that ends as myoepithelial-rich pleomorphic adenoma, that should cover all the possibilities. Comparing myoepithelioma with schwannoma, you can see schwannoma not always have spindle nuclei. Many times it just have oval to plump looking nuclei, and it has this very characteristic filamentous cytoplasm.